Very pleased to welcome Dr. Richard Russell. So over to you, Richard.
Hi, everybody. It's so lovely to be here. Thank you so much for inviting me. And actually, what's really lovely for me today with this is that this is a journey I've been on, and I'm going to present to you a lot of research stuff, some which I've been closely involved with, which is different to my other parts of my job. So it's really exciting to be able to talk about what I'm excited about with research. But also it's a journey, as I said, I've been on. And I think what's happened and our understanding of these funny little cells and how they impact on our practice with regards to airways disease, obstructive airways disease, has revolutionized, or not revolutionized, but has absolutely changed practice. And the work done in the department I work in Oxford has actually changed national and international guidelines. So I want to tell you about some of that, underpin some of that, and love to take your questions because it's really exciting. But I think, do you know what? Like all great science discoveries, it's actually really simple. So I'm really excited to be able to share that with you. So let me share my slides with you. And it's exciting to be able to do this talk actually, which it's great to do it. Right, okay, so I'm going to talk about eosinophils. I'm going to talk about eosinophilic COPD and where are we now with this and what does it all really mean? I know this sounds a bit kind of bit odd and a bit specific, and it's not really, because I think it has application to so much of what we do. And also, Joe, going back to your point, it really shows how ignorant we are about what goes on and what the cells actually are doing, because I was like you until a particular young now professor of respiratory medicine came to work with me when I was a consultant at Wexham Park. I had no idea about this, but it's actually really obvious. This is my disclosures. I'm biased. I treat COPD patients. I research COPD patients. I talk about COPD a lot, and forgive me if I bore you. And many of you have heard me talk about COPD before, and I've shared platforms with some of you before. And I work in a department that loves eosinophils. I work very closely with Mona Baffadel, who is this particular young lady, and Ian Pavold, who I'm sure many of you will know, and I've written a fair bit about these now. I'm going to talk about eosinophils. I'm going to talk about the burden of eosinophilic disease, and what goes on and what's underpinning where I think we can apply them in practice. So one of the things we've never had in COPD, and we've never had in respiratory disease, are biomarkers which actually really work. And by that, I mean something which we can measure that changes with disease severity, which changes with disease status, and then changes when we treat. And we don't have an HbA1c, we don't have a blood cholesterol, but we do have an understanding now of some of these things. Different stimuli cause different inflammatory responses. And I don't think we fully understand this, but some of the early interleukins, which are the cell signaling mechanisms that we see in the airways of people with respiratory disease, I'm talking about asthma and COPD and other things perhaps, interleukin 13, interleukin 5. And interleukin 4. And different balances of these cytokines lead to different responses. And we can measure this protein called periostin, which tells you a very similar thing to the measurement of nitric oxide. And many of you will have heard of, if not be doing, measurements of nitric oxide. And you, hopefully, if you're doing it, you understand how useful it can be in the management of asthma. No question. But interestingly, interleukin 5, which partly produces FeNO, also is the major, what we call chemotactic factor for eosinophils, and it pulls eosinophils from the bone marrow through the blood into the airways, which is where these cells then gets a bit naughty, and they can do things which can be beneficial in some ways and also very harmful as well. So these are important things. And so just want to say, what do eosinophils do and what have they done in the past? Well, classically, and many of you will know that they are part of our body's first line defense in our mucosa, our skin, our esophagus, our lungs, and in our guts, particularly against helminths, against worms. And there are some beautiful videos on YouTube of watching these eosinophils eating up worms and things. And of course, in the modern world and in the world we've evolved from many millions of years, eosinophils do different things now. And very often, eosinophils in high numbers and in the wrong place are associated with disease. And that's true in myocardial infarction, where they're then found in the tissue in the myocardium, in the tissue in the heart, and in other problems. And you will have maybe heard of eosinophilic esophagitis, eosinophilic inflammatory bowel disease, and of course respiratory disease. So let's look at some definitions. What do I mean about eosinophils, eosinophilic COPD? Well, the early work was done, and I just illustrates perhaps how stupid we were. We were doing lots of work, and I did some of this on sputum. Respiratory physicians love sputum. Most people in the world hate sputum, but sputum eosinophils are really helpful. Sputum is really useful to look for eosinophils in people, for example, with asthma. And sputum was diagnosed as eosinophilic if more than 3% of the cells that we find in sputum is eosinophils, are eosinophils, and it's associated with up to an increase. It's stable state between different patients. It goes up with exacerbation. Most of it comes from asthma, and it is associated with response to corticosteroids, oral corticosteroids, and a reduction in exacerbations. Now, one of the things which changed was that Mona Baffadel, doing her work at Leicester, which is one of the major centres for studying sputum and sputum eosinophils, was she noticed two things. One, we know that actually looking at sputum is pretty horrible, and it's really difficult. And doing it in clinical practice is practically impossible. But she also recognized there was a tight association between blood levels of eosinophils, or relatively tight association, and sputum eosinophils. And could that be utilized? So here's some work done by Chris Breitling from Leicester, which showed that sputum, I'm going to show you some sputum data to underpin all this, that sputum eosinophils, higher levels, were associated with improvements with oral corticosteroids, both in lung function, exercise tolerance, and also changes in quality of life, or disease-specific quality of life. So the higher the level of eosinophils, the better the response to steroids. Similarly, further work showed that if you use eosinophils, sputum eosinophils, to increase or decrease therapy, you can, in COPD this is, show a reduction in admissions. So we had one group of people, very similar to some work that was done by Ruth Green in Leicester, one group of patients who had standard care versus one group of patients whose treatment was increased or decreased, particularly steroids, based upon their eosinophil numbers in their sputum. And you can clearly see that actually the patients who had the eosinophil measured, monitored and responded to had lower levels of attacks. So it really works in that way. And again, more work from Chris Breitling from the similar work showed that actually lung function was absolutely predictive, as I said, by the inhaled corticosteroids in this case, with the higher levels of eosinophils having greater responses to steroids. But what you can notice from those previous studies, and this one, is that they divided things up by cut points, tertiles. And I'll come back to that. This was a tertile thing, and previously you can see this was done by 3% cutoff only. And so basically you can see that there was no real understanding of the level of them. And what Mona did was to notice that if you took blood eosinophils and then took the mean blood eosinophils of those tertiles, for example, you can clearly see that the people with lowest had a blood eosinophil about 0.15, 150 cells per microliter, and the highest were about 0.37, 370 cells per microliter. So could we not just use blood rather than sputum? Because sputum is horrible and difficult to do. So is it there? Absolutely. Sputum eosinophils in COPD are there, 40% of COPD patients, and as I've said, it predicts response to steroids. Blood. There was no definition associated with clinical outcomes with blood. Relative counts had been identified between 2 and 6%, and absolute counts somewhere between 150 and 400 cents. You will be aware, and I think coming back to Joe's point about how we were educated, actually, and one of the problems with how we were educated, that we were told that looking at blood, you had to have a level of eosinophils greater than, say, 350 or 400 to be defined as having blood eosinophilia. Well, this isn't actually true, because normal levels of eosinophil actually are much lower than that. because we did some work which clearly showed that the hematology reference values included those people with atopy, with nasal disease, and other problems which drove a slightly higher level of eosinophils. So when you took those people out of normal ranges, weirdly enough, the normal range comes right down to a level of maybe 150 to 200 cells. Just to show you, do blood eosinophils go up in asthma? Yes. Do they go up in COPD? Yes, the same as in asthma. And there's a degree of eosinophils obviously in the normal population as well, but different to the asthma and COPD patients. So 18.6% of COPD were more than 400 and 21% were more than 400 for asthma, as defined by hematology, which, as I've said, was not quite right. So this includes the levels. If you take out, this is the data we did, if you take out the atopy, you can see that that the level comes right down to a mean level of 150 with upper limit of normal of 270. And that really helps us. Because it makes you think, hold on a minute, I've been thinking of eosinophils as a high level of leading high thing, when in actual fact, you don't need it that high. If you then use that cut on the data, for example, this is some of Mona's data from Leicester when she did in Leicester, you can clearly see that actually the numbers go up significantly, 30% of COPD and 44% of asthmatics. So it is there, it is real, it is perhaps useful. I'll show you those in a minute. One of the other things that's questioned about eosinophils is the reliability of them. Are they stable over time? And do they change in people? When should I measure the blood eosinophil for them to be valid? So what we did to look at that was look at a whole bunch of people with a really nice public health statistician called Liz Millett. Looked at a whole load of patients. And every single, on this graph here, every single line you can see, every single row of dots is one patient. Okay, and so you can see, for example, the very first patient has got 2 little dots, and that was measured, 2 eosinophils were measured twice. Some of them had it done 4 times, some 5 times. And we then stratified people, just to help us understand this, into people who had low levels of eosinophils, always below 400. Some people had high levels of eosinophils, those are people in red, always above 400, and those people, that, as you can see, wobbled around. You can see that in general, for most patients, the eosinophil level is fairly consistent. If you're low, you tend to stay low. If you're high, you tend to stay high, with about 20%, 23% wobbling around in the middle. And this may be that they have variable allergies or seasonal issues, as opposed to, so when they take the blood test, it will vary a little bit, or having exacerbations. So you can see how this actually works quite well as a marker. And I'm not going to talk particularly about cutoffs, but actually using that cutoff actually seemed to define patients quite nicely. People stayed below or people stayed above. And if you look at the interclass correlation coefficients of this particular measure, blood eosinophils comes out the best, better than sputum eosinophils, better than neutrophils. Blood eosinophils is pretty good. And if you look at things like cholesterol or troponin or any of those other things, this measure matches up very well indeed. Okay, let's look at what they mean. Let's look at what eosinophils may actually mean to people. Well, many studies have happened now epidemiologically, which have looked at blood eosinophils, with higher blood eosinophils in this particular study from Holland being related with COPD death, an odds ratio of 4.8% at time of exacerbation, independent of atopy. Again, another study showed again a further level of higher mortality, and interestingly and very importantly, this is early work from 1999, which shows that high levels of blood eosinophils are associated with higher cardiovascular mortality. And guess what? The ETHOS study that's just been published looking at triple therapy in COPD has very clearly shown that the mortality signal that we're seeing in that study is due to eosinophilic disease with reduction in cardiovascular mortality with treatment. So this is not just totally respiratory focused. Interestingly as well, and you'll be aware of the Decaf score perhaps in COPD, that low eosinophils are absolutely a marker of infection risk. and that the lower your eosinophils, the more likely you are to have a high CRP at time of exacerbation, and also an increased risk of bacterial infection. Decaf score looked at is a mortality or prognosticating score for people admitted to hospital with COPD, which clearly showed that if you've got low eosinophil counts, you've got a significantly increased chance of dying. Why is that? Because you're much more likely to have sepsis. And guess what? Giving people steroids in when they've got low eosinophils and sepsis is perhaps not the best thing to be doing, but perhaps we'll come back to that and can discuss that. But eosinophils are really useful for predicting infection. The lower they are, the more likely you've got infection and the longer you stay in hospital. So let's look at some of the data now, the intervention data. So this is the INSPIRE study. Was a double-blind, double-dummy study with salmeterol-fluticasone versus tiotropium bromide, looking at exacerbation risk, and they were quite surprised to find that actually tiotropium was as good as salmeterol-fluticasone. But interestingly, when they cut it by eosinophils and broadly just cut it at 2% eosinophils, you could see that once you got above 2%, the steroid-containing arm in blue stayed steady. But the non-steroid containing arm, the tiotropium arm alone, increased the exacerbation rate. Interestingly, where before the vice versa was true. So this was one of the first studies that looked at this. If you look then at some nice data that came from a group of studies done by GSK, put together by Mark Dransfield and Steve Pascoe, looking again at LABA-ICS combinations, so steroid in blue versus LABA alone, butyl bronchodilator alone in orange. There's 3 or 4 important things that we can tell from this graph. Number one, as your eosinophils go up, and they cut it at 2%, 4%, 6%, 8%, 6% or more, your risk of exacerbation goes up if you haven't got steroids. Number two, if you have steroids, your risk of exacerbation stays steady. It doesn't drop. It goes 0.8, 0.9, 0.8, 0.9. It doesn't drop, but it stays steady. So the eosinophil effect is controlled. And then the other really important thing to take from this study is that if your level of eosinophils is below 2%, and it's just a number, don't worry about that, below 2%, then steroids make no difference. So the message is clear from this study. If you've got high eosinophil levels, you should give people inhaled steroids. If you've got low eosinophil levels, you don't need the inhaled steroids. Again, another study, the forward study looking at beclomethasone fluticasone, beclomethasone formoterol rather, again cutting by this time by eosinophil numbers, showed exactly the same. That if your blood eosinophils are low, there was a small reduction in exacerbation in this group. If your eosinophils are high, there was a flatlining of exacerbation rate with a big difference between those with steroids and those without steroids. So very useful. This then comes to Mounas' work, and I think this is really important. It's been published a couple of years ago now, and really changed things, because what she did was say, do you know what? People don't have cut points. People don't have, oh, there's a difference between 2% or 1.9% and 2.1%. There isn't. That's ridiculous. Because today my eosinophil number is 220, tomorrow it might be 170. Does that mean I've changed behavior? No, of course not. So what she did was to consider eosinophils as a continuous variable. So your number is your number, the number measured on that day, whether it's 220, 230, 400, 500. And she took all of the budesonide formoterol LABA-ICS studies, which had eosinophil numbers, and she plotted exacerbation rate against eosinophils as a continuous variable with no cut points. And she showed in a different way, but exactly the same as before, that if you have inhaled corticosteroids, irrespective of your eosinophil number, your rate of exacerbation stays flat. She showed that if you don't have inhaled corticosteroids and your eosinophil number is higher, you have more exacerbations. And also she showed that if you look below maybe 160, 150, that if your blood eosinophils level is lower than that, the graphs cross each other and there's no benefit of the inhaled corticosteroids. Okay. She converted this into a risk ratio. showing the difference between the two arms opposed to by eosinophils, showing that actually, as I said, below say 150, 130, whatever it is, there is no real difference between the two groups. But as the eosinophils go higher, the benefit of exacerbations seen by steroids is increased. And this allows us to do something really quite clever, because we can then say, hey, to get to the 50% exacerbation rate compared with your control of 1, you need to have an eosinophil count of around 340. And in her population, this occurred in 25% of people in the studies. So this means for your patient who's having 2 exacerbations a year, whose eosinophil count is 340 or higher, if you give them inhaled steroids, you may reduce that 2 exacerbation rate down to 1. So it gives you an idea of potentially risk and benefit for the role of inhaled steroids. And if you then take, for example, a 25% reduction in the exacerbation rate, which occurs in 80% of people, you need an eosinophil count more than 100. And again, if someone's only having 1 exacerbation, does a 25% reduction of that 1 mean you need to give them steroids? For me, perhaps it doesn't. But you can see how you can translate exacerbation risk, which is usually driven by previous exacerbation history, with the benefits that they're going to get from the steroids versus risk of steroids. This is a very old study. This older study it was one of the very first studies looking at the effect of inhaled corticosteroids. These people were not on any other drug. No other drugs existed. That's not strictly true, but in about 1998, and Joe and I will remember those days. But this was a study looking at clean patients, and it was designed to see whether fluticasone, given in reasonably big doses, made a difference to the decline of lung function. Okay, and the answer to that study, done by Sherwood Burge from Birmingham, was no. But later on, they reanalyzed the data because they didn't see it. They missed it and put a cut point in of 2% blood eosinophils. And you can clearly see, well, I think it's reasonably clear, that actually, if your levels of eosinophils were above 2%, the difference in the treatment arm versus the non-treatment arm was significant. So actually, patients clearly benefited from steroids if they had a higher level of eosinophil count. Just a thought. However, it's not all that clear. If you look for other things, this is data from the Wisdom study, which was a withdrawal study. So you had patients on triple therapy, so LABA, LAMA, and ICS, and you took away the ICS. And this study showed over time that there was no real difference in a year's time, that those people who were left on steroids versus those people who had the steroids taken away from them, suggesting that you can take the steroids away. Okay, and the hazard ratio was 1.06, not particularly an issue. However, if you then reanalyze, and this was done by Dr. Watts from Germany in 2016, you examine that by blood eosinophils, you can see that around the 300 to 400 blood eosinophil number, taking steroids away leads to an increased risk of exacerbation, which is useful and helpful information. How many patients were that in? Well, in this particular study, that was about 20% of patients had more than 300. 80% had less than 300. So, this has led to some of the changes in guidelines. What about the future? Well, should we be targeting blood eosinophils in COPD like we do in asthma with drugs such as benralizumab and mepolizumab? Well, there is some positive data. If you look at benralizumab, for example, which is a very rapidly acting IL-5 receptor antibody, in 100 patients given with sputum eosinophils more than 3%, which we would want to use blood now, you can see that there is a significant effect of the blood eosinophils on the exacerbation rates when on treatment. And so actually they seem to make a difference. And if you look also at lung function, there seems to be a lung function effect when given antibody anti-IL-5 therapy according to eosinophil rates with using the blood. It's not a massive effect, it's a significant effect. Is it enough to justify treatment? At the moment, not quite. But let's see if we can further revise the phenotyping to predict response to treatments like benralizumab. Is it a signal for exacerbation risk? Absolutely. And again, in the Copenhagen lung study, which has been ongoing for many, many years in over 7,000 patients, a cut point of 340 cells driven by the data led to a relative risk of exacerbation of around 1.7. And in a primary care population from Britain, an exacerbation risk of 1.32. So it seems to help for this. And if you look at blood eosinophils, this is a receiver operator curve for the risk of exacerbation using blood eosinophils. The receiver operator curve showing sensitivity and specificity is best for blood eosinophils. So further work that Mona did, and this is part of her PhD she published, was looking at exacerbations. And what she did with exacerbations was take people and look at how they were treated and look at whether they had blood eosinophils or not raised and their outcomes. So if you're on the biomarker arm and you had blood eosinophils, you were given steroids. If you were on the biomarker arm and you didn't have eosinophils, you were not given steroids. Versus the standard arm, which is where everybody gets steroids, which is what we do. And if you then look at these things called treatment failures, and I know numbers are quite small, but treatment failure is a need for retreatment, rehospitalization, or death. You can see a few things. Number one, if you give people placebo, if you've got low blood eosinophils, there's very few treatment failures. If you give people prednisolone and they've got blood eosinophils, there's very few treatment failures. But if you give people with negative eosinophils, low eosinophils, prednisolone, there are more treatment failures. And if you give people with eosinophil steroids, there's also a similar number of failures that we see in the arm. So treating people with the right characteristic with steroids in exacerbation may well be very important. And I've done other work that published that have shown that actually this is absolutely true. If you look retrospectively at people who've got blood eosinophils in admission to hospital, that actually the treatment outcomes are directed by what treatment they get and the blood eosinophil level. Well, there's not all the data lines up. So it's an outlier. This is from the FLAME study, which was again a big LABA-LAMA versus LABA-ICS study looking at exacerbations of COPD. And there was an overlap between 150 and 300 cells in this study. So it's not absolutely firm. So there's more work to do based on the definition and the epidemiology of the eosinophils and looking at FEV1 symptom exacerbations as well. And Mona did show this in her other work. We need to do more prospective studies. We also need to look at quality of life and the economic burden of this. But there's very clear signals, I think, here to take us forward. So what's my ask of you? What do I think you should be doing? And Joe, going back to what you said at the beginning, when we started, we weren't looking at blood eosinophil numbers other than in the context perhaps of severe rhinosinusitis and severe asthma. But we must be looking at blood eosinophils now in COPD, and that message is out there. And people are doing this. If people have low eosinophil numbers, less than 100, they don't need inhaled corticosteroid. They need to be maximized, optimized on dual bronchodilators plus other therapy to prevent exacerbations. If they're stable and they have relatively low eosinophil numbers, then you potentially can withdraw steroids if they're on them, and you need to consider you probably don't need to start them. But if their numbers above 300 and they're having exacerbations, then I would certainly treat with inhaled corticosteroids. I think the risk-benefit ratio is absolutely there. And further data showing the benefits on cardiovascular mortality is really exciting and interesting too. And I do believe we need to consider eosinophils when people exacerbate, because if their numbers are low, they've got sepsis, and steroids may not be the right thing to do. So I hope that's clear. I hope that's been slightly illuminating. It shows what we don't know, and I'm very happy to take questions now. Thank you, Joe.
Let me do my little hand clap for you, Richard. Thank you very much there. Yeah, and you won't be surprised to hear that it started drilling outside my house at the moment. So I think Julia's going to manage the questions and go to. There's been a couple of people first.
Yes, thanks, Joe. And that was really fabulous, Richard. I have to say, I was taken back to a talk that I heard Peter Barnes give at the BTS, I don't know how many decades ago, where he talked about how we'd always thought of asthma as eosinophilia and COPD as neutrophilia, and sort of the eureka moment of actually there are eosinophils in COPD as well.
It's just, and also Julia, you know, COPD wasn't a steroid responsive disease, and we always thought this was because it was neutrophilic, but we were looking in the wrong place. That's the key.
Yeah, no, really fascinating, I have to say. So brilliant. Right, so in the chat we have got Angela Scott has apologized that she may have missed it, but what is the impact of eosinophils only being taken after OCS, as often patients are given a dose pre-bloods or full blood count, which may suppress the count?
Okay, a couple of things. It's really good, and I'll come back with a practical point on that, Angela. You're absolutely right. If you give someone oral corticosteroids, eosinophils disappear within hours, okay, really quickly. So you can't take a level after you've given oral corticosteroids because they push them back into the bone marrow. They disappear out of the blood, okay? And that's just the way that the cells work and how steroids work really rapidly to suppress the IL-5 response in most people. So you can't do it. You need to try and do it in steady state. Having said that, you can use historical numbers. So if you look, we've all had blood counts done. You know, we all know, we should know our eosinophil number, perhaps. You know, I don't know what mine's about 110, I think. So, and it doesn't change very much in steady state. So you can use patients' numbers from the past, and in general, I would kind of pick the higher ones because that you know, because unless you know that they're seasonally atopic, where they go up and down like a yo-yo. Because as I showed you, the ones high kind of stay high, and the ones low stay low. So I think you're absolutely right. Avoid steroids, but otherwise just go historical and pick the higher one.
Brilliant. And following on, really, so we have a question or a request from, forgive me if I can't pronounce your name well, but Didier Hungwe, who says, could you kindly repeat the eosinophil levels when ICS are beneficial and which level when they're not? Thank you.
Okay, that's a really good point. And I just want to be really clear. I'm going to make this really simple and also really complicated. You need to consider the individual patient's levels. So looking for a cutoff. We all want cutoffs. We want to say 100 is different to 105. It's not. So we mustn't look not just totally for a cutoff. Okay. So what I'm saying is you need to look at the patient, and in general, people below 100 don't need steroids. Okay. They don't benefit from steroids in any of the studies that have been done. People above 300 in general probably should have steroids unless they're absolutely not exacerbating, and I've got a couple of those because steroids lower exacerbations. So if you're not having them, you're not likely to start having them, but 300 is a reasonable cutoff for increased risk of exacerbation. And then between 100 and 300, you've got to consider the individual's risk and potential benefit. So as I showed you, if you've got a number around 250, I'm going to get about a 40% reduction in exacerbation rate. So if I'm having 5 exacerbations, there's no brainer. I'm going to give them steroids. But if they've only had 1, I might not. And you have to weigh up for individuals that risk benefit of this steroids. And I've not gone into steroid risk, but the other thing we worry about is pneumonia risk. And again, that would be associated with age, with previous episodes of pneumonia and potential other comorbidities. So I'm kind of, that's how you have to do it. So remember those 100 and 300 numbers, I think are pretty good ones. And I would say above that 300, the risk benefit is absolutely in favor of steroids.
Okay. Thank you. And yeah, interesting. So Emma Davies is asking you to clarify, Richard, please, that when you're treating an acute exacerbation of COPD, if there are no BE, is it sepsis? Is that what you meant? Yeah,
that's Emma. That's absolutely right. The Decaf score is brutal on this. You know, the Decaf score absolutely found that if you've got low levels of eosinophils, and they pick 0.05, so it's 50 cells. Okay, so it's really not many at all. Your risk of dying is rapidly increased, and that is absolutely, you just look at this, and I would love you just to grab some patients. The CRP and eosinophils are absolutely inversely correlated. So as your CRP goes up, your eosinophil comes down. As your eosinophil goes up, your CRP comes down. And I think that's because of the drivers that's going on. So there is no question in my mind that we need CRP. So some other work Mona's done has shown that really the CRP cutoff around 40, you should give people antibiotics in exacerbations of COPD. If the eosinophil level in that will be fairly low. If it's higher, the eosinophil level goes completely down, and you must give them antibiotics. So I think it's not hard and fast rule, but I think it's a very good rule actually. And we also see the similar things with COVID actually as well. So there's some really interesting pathway shifts that go on depending upon the stimulus. And so yeah, you can. I'm not saying you absolutely should use it, but we'd use the CRP for starting antibiotics. And I think confidently, and Joe and others may disagree, there's certainly, I think the future may well be that when people have exacerbations, we will divide them into I'm going to be a bit brutal here, D-dimer driven, troponin driven, neutrophilic driven, bacterial infection driven, viral infection driven, airways bronchoconstriction driven, and I'm just going to make up any other kind of phenotypes you might consider, and eosinophilic or non-eosinophilic, and we will treat them differently, because what we do now doesn't always make absolute sense, and the outcomes are different.
And Emma's come back to you in the chat, Richard, saying, could it be due to the initiation of OCS?
Well, I think, again, that's a really good point. I think in the Decaf score, no, because I think we're very clean at the front end. There's always, and actually when you look in the big picture, big numbers, which is what I did for every admission to Oxford, I looked at, I ignored treatment they'd had before and then followed them through with treatment with eosinophil numbers. And actually in the big picture, it's usually they haven't had the signals there whether you've had steroids or not. You absolutely will lose some of those patients because of steroids, absolutely. But usually it's because there's infection. But again, we wouldn't necessarily give steroids to people with raging pneumonia just on a whim.
Right. So now the home medication. So Lindsay Joy wants to know how on earth you can now deal with rescue packs given all this.
Lindsay, I think so. A couple of things. With my other hat on, I really think that we should have point of care blood eosinophil testing, as part of the kind of exacerbation kind of assessment pack that people could kind of do it. We're not far off it. We've certainly done some studies on point of care eosinophil testing, and I think they should be included in the diagnostic centres and things like that to give people an idea of where they are. And actually, yeah, people could make decisions based upon those. Again, the rescue packs are a moot point anyway about how we do it, and the key is clearly how to use them better and educating what an exacerbation is, etc. But they're here, we've got them, and patients self-manage, which is sometimes a good thing and sometimes a bad thing. But I would love to have, point of care eosinophils. When someone's getting worse, they finger prick themselves, get their eosinophil count, and then treat appropriately.
Right, so a bit like doing your blood sugars.
Absolutely.
Yeah. Cool. And Elspeth Potten apologises because she's had to step out a couple of times. She might have missed it, but I don't think so. Is there a role of pheno in equivocal cases?
Tricky question, really difficult question. Okay, pheno comes from a different pathway. It's mainly the IL-13 pathway. However, it's a mark of airway alveolar eosinophils, but that's different in asthma to COPD. And then you've got the confounding factor of smoking, etc. as well, which pushes pheno down a bit. So pheno is less useful. I'm not going to say it's not useful. And my journal has published quite a lot of work that show that if you put some of these things together, there is some utility to it, and it does predict steroid responsiveness. And in every study I've ever seen, not so sure about COPD, but certainly in asthma, if you've got a high pheno level, and I'm doing a study at the moment with this, if you've got a high pheno level and you give someone steroids, guess what? They get better. So, and whether it's cough, whether it's asthma, whether it's COPD. So if you wanted to chuck a pheno in, I would not be against it. And if the pheno level was above 45, which is what the kind of the guidance for asthma takes, and I would go perhaps even a little higher, then they are likely to, and the cough guidance would say 40, they are likely to respond to steroids. So it could be used.
Okay, and Vicky Knowles is sharing an article on the PCRS website. So you're getting thanks for those nice fulsome answers to the questions, and Joe has thrown a little curveball out. maybe eosinophil level, something we should be having in a patient passport along with oxygen sensitivity.
Yeah. Why not? And actually, why not? And actually, would take out some of the guesswork and people having to look, because people tend to stay similar. You know, people do at exacerbation go from having low eosinophils to high eosinophils. Some people don't. The problem with that is you do need to look at the individual stimulus, so it's maybe not totally predictable and reliable. And I guess we're looking at fairly small relative harms if we do overtreat with steroids, perhaps in some people. But otherwise, yeah, why not? More information, the better. Or more better than that, Joe, would be not maybe on a patient passport, but on an app, which you can look at your relative risk of disease, that you can put like we do for lung cancer, and when we look at size of nodules and where they are and stuff, you could, or for blood pressure, risk of stroke, you could plug in eosinophil numbers, FEV1, exacerbation rates, other things, and see where your risk is. So that might be very useful.
Joe says, "Oh, she's so old-fashioned." So at the moment, I can see no more questions in the chat. So this is Last Chance Saloon. If you have a question for Richard, and clearly that raised an awful lot, Richard, and lots of thanks in the chat from various people saying it was very informative, very clear.
No, it's just brilliant. It's brilliant to be here and brilliant to do this. And actually just say we've come on such a journey. We now look at eosinophils, which we didn't look at before. I didn't look at before. And people around the world this is a primary care message. People around the world are looking at them now, and it's making a difference, I'm sure.
Yes, great. And Alarise Bigger says, inspiring and great information on treating patients for how they present. Thank you. So lots of thanks there. Joe, did you want to come back in?
No, just to echo all those things. Thanks, Julie. I think your job now.
Your drilling is still with you. So, Richard, I think it just leaves me on behalf of everyone to thank you so much for a really informative and very clear talk and lots of food for thought. So thank you so much.